All right, good afternoon, everybody. Hopefully you're all staying awake. This is the time of day when I know I start yawning a little bit more, so I'll do my best to keep you awake. I'm Judy Weisenberg. I'm a pediatric neurologist and the director of our CDKL5 clinic at WashU in St. Louis. I'd like to start just with a few disclosures, or lack of true disclosures, but just like to share that I was a site PI for the ganaxolone study as well as for some Rett studies, and I do get funding from a number of related sources. As is no surprise to anybody, we are going to have to discuss off-label use of FDA-approved products. So a little bit more introduction, and I have permission to share both of these photos. The young lady who's a bit older is the first patient I ever met with CDKL5 deficiency disorder, and the adorable little baby is my most recent patient that I met almost exactly 15 years later. And that's how I came to be here talking to you today. I trained as an epileptologist. I finished my fellowship in June of 2009. Really had only worked 2 months because I took a little maternity leave in there, and then I met the young lady with the bow in her hair. And that led me to start asking even more questions about what we really know about treating epilepsy, particularly in genetic conditions. And in the past 15 years, I've learned a lot, but we still have a lot more to learn. So just a brief outline of what I'm going to talk about today. I'm going to talk about the role of surgery in the treatment of epilepsy, but really looking at it through the lens of CDD and what we have available to us for epilepsy. And then I'm going to get into some very specific details on 3 key surgeries. When I talk about DBS, I will briefly reference RNS because there is some overlap. And then I'll talk a little bit about navigating decisions. So I don't think this is probably news to anybody in this room, but I just like to sort of set the stage. We all know that epilepsy is a pervasive problem in CDD. The vast majority of patients deal with it. It typically presents in the first month to 2 of life, and those seizures change really fast at first. Then many, in fact the majority, do develop epileptic spasms, whether it's recognized or not. And then after that, there's a continued evolution until we get to, for many, a period where they are having predominantly tonic seizures, those whole body stiffening seizures that can be quite intense, and for many are daily. But there's also a honeymoon period, and that can typically happen between stage 2 and stage 3. It can be anywhere from a month to 3 months. It can come, it can go. And all that adds to the complexity of figuring out whether a treatment is working, because sometimes you're just in a better time period. And so we all, the saying, correlation is not causation, but it's a logical conclusion when things seem to be better. The therapeutic approach to pediatric epilepsy, when we're talking about trying to prevent seizures, we have medications, we have diets, and we have surgeries. But it's a whole lot more complicated than that. So as we think about our approach through the lens of CDD, we think about the fact that for many, seizures are daily, and we're dealing with a variety of challenges. For instance, in general, medications have less pediatric data. It's easier to get medications approved for adults, so that's why, for instance, Depakote still is only approved for adults. Did you all know that? Every now and then I get an insurance company that sends me a mailing to inform me that it's not approved under age 18. A lot of the data that we have is off of a much broader category called Lennox-Gastaut syndrome, which is a pediatric epilepsy, which does present usually by age 3 to 5 and has predominantly tonic seizures. But it's actually a grab bag diagnosis because, I don't know if all you know this, but there are about 1,000 genes that have now been reported to be associated with causing epilepsy. And for Lennox-Gastaut, we're probably talking about at least 500 of those genes. So saying, oh, this medication works in Lennox-Gastaut syndrome, I think that's part of why the data in these studies is so mixed. And then, of course, as we all know, there's minimal, if any, evidence specific to CDD. A lot of it is what we call retrospective data, like the beautiful study that Helen presented just now, but it's looking back. It wasn't an organized, let's take 200 individuals and give 100 of them the same exact treatment at the same exact age. And so there are a lot of variables that could be affecting those results. This is an older version of the slide that Raj presented, but basically there are a lot of medicines. But there are things to really consider when you're implementing medicines. We want to go slow and steady. It's easy to say, oh, it's clearly causing a problem. But is it the new medicine or the interaction with the other medicine that you had on board? Is it that they're sick right now and you need to give it another week? So being very methodical. I'm not saying stay on the same exact treatment plan for 5 months when you have a problem, but just being very systematic, not making changes too fast, but being systematic. As I mentioned, seizures naturally fluctuate over time. There can be a honeymoon period. You also have to think about your individual child. We've tried medications in this class before. Even though somebody else on Facebook may have said it was the best medication ever for their child, that doesn't mean it's going to be the best one for yours. And side effects, they can work for or against us. So a higher dose at night makes your child sleepy. Well, that might be a good thing at night, but it wouldn't in the daytime. And then most importantly, having a thoughtful relationship with a primary neurologist. And it could be wherever is best for your family. I do not claim to have all the answers. I don't think any of the COE directors do, because we're all constantly learning. I'd like to think I know more than I did 15 years ago, but I'm still learning every day, and I learn from my conversations with my patients and their families. I hadn't thought of that before. Oh, that's an interesting thought, that's a new idea. So but having that trust and that interaction, that give and take, is really helpful to get the best outcome. Some special medication considerations. We have some specific data on Ztalmy. I do not think it's a cure-all, unfortunately. I wish there was one medicine that's a cure-all, but I do think that it is worth considering. But one of the things that I've found is that it is sedating, and you do have to be careful about what other medications you're on at the same time, particularly benzodiazepines and vigabatrin at the same time. You may have to decrease the others because some children are more likely to seize more when they're overtired. So you sometimes find that it's working against you, and it may be a matter of adjusting your dosing or your scheduling of the dose to get the benefit. We're all watching Fintepla or fenfluramine with interest. The data is very good in Dravet syndrome, which is a completely different genetic condition, and I'm very curious to see what we can learn beyond what we already know in the Lennox-Gastaut syndrome data. And then X-Copri, I know somebody had asked in the previous hour, we do not have good data on it for developmental epileptic encephalopathies, DEEs, or Lennox-Gastaut syndrome yet, but outside of my CDKL5 patients, I have a clinic full of complex epilepsy patients, and so I have been using it. I want to be very clear. Number one, it is only approved in adults, and number two, we do not have good data. But so far in adults, the safety data is very good, and there is some suggestion that it may be efficacious for individuals with the types of seizures we see in CDD. So it's worth paying attention to and thinking about over time. Hopefully we'll have more information in the future. IVIG and steroids is another form of medication that can sometimes, these are anti-inflammatories, that can sometimes be utilized to give you a honeymoon period. There are pros and cons, and thoughtful discussion needs to happen. Also, IVIG is intravenous, which, as you can imagine, comes with some challenges. But it's worth thinking about if you're wanting to try a different approach. And again, it's important to have a thoughtful relationship with your neurologist so that you can have good conversations about this. Another question to think about as we move into the heart of the talk, which is the surgical approaches, is what is the goal? I think we would all agree that we want to optimize development, we want to optimize quality of life, and we want to minimize the seizures, but we also want to minimize the risks of any treatment, we want to minimize the side effects. And unfortunately, as things stand, you're always going to be going, which is worse? And it's important to be stepping back, and that's where clinic appointments can be really good, because usually they're not weekly. Hopefully they're, every few months, and that gives you that window to go, okay, this is where we were, and this is where we are now. Are we in a better spot than we were before? If we're not, why is that? So, now I'm going to move into talking in some detail about surgeries. And really what I hope you'll take away from this is that surgeries are also unfortunately not cure-alls, but sometimes they can minimize the number of medications needed. They have the potential of being less sedating. And they're another approach that I really think gets used as an adjunct with medications. In many ways, it's kind of like a medication trial, but the unfortunate part is you have to put the risk up front. I also want to be clear, I don't think surgeries are better than medicines. It's just important to know what all your options are. So probably most of you know this information, but the VNS is a small pacemaker type device. It's usually placed in the left side of the chest. It's currently only approved for children 4 years and up, but I have many times had it placed in children who are much younger. They do need to be a certain size to be big enough for the device and the wire, the leads. So the device is placed under the skin and the wire is attached, and it connects to a small electrode that's placed on the vagal nerve, and it can be programmed over time to optimize the settings. How does it work? Well, this is a major oversimplification, and the truth is I'm not sure we actually fully understand how it works. But it's stimulating the vagal nerve, and there's a baseline frequency that can be adjusted. And there are actually a variety of parameters: how strong the current is, how often it goes off. And even now with the newer models, you can even have a different setting in the daytime than the night, which becomes important for a variety of reasons. There are also an auto-stimulation mode with the newest model, which allows, if the heart rate consistently elevates with seizures, it can send an extra impulse if it notes that bump in heart rate, which might help improve seizure control. There's also a magnet that can be swiped when you're witnessing a seizure to see if you can stop it. Obviously, some of that depends on the typical duration of the seizure, because if the seizure is super short, by the time you swipe the magnet, the seizure might be over. But depending on how long your child's seizures are, it might be beneficial. I think it's very important to know practically what you're getting into when you have a surgery like this. So you're talking about 2 incisions. Neither of them are particularly long. Sorry, I don't know if you guys can see my hands, but a couple of inches on the chest, skin incision, and a skin incision on the neck. And this allows the device to be placed, and then the wire is threaded and the electrode attached. It actually can be done as an outpatient procedure, and the patient can potentially be discharged home, and we actually will do that with the majority of our patients, but we take into consideration how they wake up after anesthesia, how far away the family lives, how overall medically stable we feel the child is. They might stay overnight, but it's usually not a long hospitalization. Different centers will do this a little bit differently, but the VNS is usually turned on in the OR at low settings, or it might be at the first post-op appointment with the neurosurgeon where they verify that the incision is healed well. After that, it does have to be programmed and adjusted over time. Thankfully, the newer models allow you to adjust the settings, and you can actually create a programming calendar that allows you to do up to 8 settings, and typically we'll adjust the setting every 2 weeks. So that means that you can get 2 months worth of settings done, 4 months of settings done in one appointment. Now, if there's any concern that an adjustment isn't tolerated, unfortunately, you do have to come back to a person who knows how to program the VNS to get it set. Unfortunately, we can't do it remotely. So these are some very practical things that I know that it's important to think about before you commit to this kind of a device. What about side effects? Overall, it seems to be pretty well tolerated, but definitely some individuals will notice a change in their voice, particularly when the device is going off. Some of that depends on how strong the current is or the frequency of the settings. Throat pain, cough have been reported. And I do want to emphasize that there is some evidence that obstructive sleep apnea can be worsened with the VNS. And I think that's extremely important. When you're dealing with a situation where you may be prone to lower muscle tone to begin with, that's already a risk factor for obstructive sleep apnea. So, as I'll mention in one of my other slides, I do actually recommend that you have a sleep study before you get a VNS placed. That's not an official guideline, that's a Weisenberg guideline. And there are things that can be done with the settings to minimize that risk, and I monitor for any evidence. So I'd be looking for changes in breathing pattern in sleep, noisy breathing in sleep, snoring would be potential signs that that has developed as a side effect. So what about VNS in CDD? What do we actually know for our children here? So it case series, retrospective case series. So Helen was lead author on a paper from 2018 that had 38 individuals. As always, we end up with sort of partial data, but as you can see, over half reported improvement, no change in total medications. There were some individuals who reported improvement in behavior and mood, and I should mention that there was actually some data about the possibility that VNS can help depression, and so it's not impossible that it could help mood. There are also, though, reports that the VNS was stopped, and it can simply be turned off by programming it due to side effects. In another study, this was a study that I was involved with that looked at a large cohort of individuals and all of their treatments. We had 177 individuals, 36 had a VNS, 11 reported improvement. 1 initially reported swallowing difficulties, and 2 initially reported worsened seizures. So limited data for sure. So what are the pros? As compared to other surgeries, it is much less invasive. It might decrease the number of medications needed in bigger epilepsy studies. That is demonstrated, but in CDD that has not been demonstrated. One question, which is always a scary one for us to bring up, but does it change survival? And that's a complicated topic, but in the bigger world of epilepsy, there has been some reports of fewer ICU admissions and a lower incidence of epilepsy-related death, but there's no data to say whether that changes things in CDD. The cons, surgery, right? General anesthesia. There's incisions, there's no way around it, and it's an implanted device which carries a risk of infection. Fortunately, with a well-trained neurosurgeon in a good medical center, that's almost unheard of, but nobody's going to be able to tell you that risk is 0. The other con is that you do have to come to clinic to adjust it, but fortunately with the newer models that has been minimized. It used to be you had to come every time you made a change, but with the newest model you don't have to. You definitely need to monitor airway. And one other practical issue that I think sometimes gets forgotten to be mentioned is that you cannot MRI the neck or chest when the device is in place due to the risks with the magnet. So just so you know, brain MRIs can still be done with a VNS. It has to be turned off, but you cannot MRI the neck or chest or abdomen when you have a VNS in place. So just sort of to wrap it up, on average, VNS is felt to need 18 months to see the full potential benefit. The hope is that you'll get seizure reduction, improved mood, but there are definitely potential side effects. The settings, there's really a lot to be said for, are there better or worse settings? Do want to remember that you need to monitor for obstructive sleep apnea. Battery replacement, it doesn't last forever, but the good news is the newer models may last 10 years or more, and some of it depends on the settings that you use. If you use higher settings, you're going to go through it faster. Lower settings, it'll last longer. And just sort of a couple of things that I really like to mention. The sleep study, consider using the nighttime settings with lower settings at night if there's any concern about impact on breathing. And my overall approach is to use a lower output current and a rapid cycle sooner, which are some technical terms about how often it goes on and off. Not good data on a lot of this, but just been my experience. So I'm going to move into talking about corpus callosotomy, which is certainly probably the scariest sounding of the surgeries that we consider. Just so you know, it's actually one of the oldest epilepsy surgeries that's ever been done and started being performed in the 1940s. There are 2 standard types. One is a complete, where you really try to make that disconnection between, so we all showed in a side view, and we seem to all have the same image that we show. But this little white bridgy thing here in the middle of the brain, that's the corpus callosum. And with a complete, you're really trying to get an incision down the complete midline from the front to the back. But you can also do an anterior 2/3. It is not considered a curative surgery for anybody, but what you're trying to do is decrease the intensity of the seizures. So particularly for people who have tonic-clonic or tonic seizures where their whole body is really stiff, they're having pauses in their breathing. The hope is that the seizures will be much milder. I have had patients actually have a period of seizure freedom after it, but that is never the expectation. Believe me, nobody complains when that happens, but it's never the expectation. Typically, seizures do recur over time, but the hope is that they'll be milder. One of the biggest newer developments is that we now can do it using a laser technique, which is much less invasive than a craniotomy. But obviously, these are sort of your big take-home points. I'm going to get into some more details. You cannot undo a corpus callosotomy once you've done it. And that is, of the procedures we're talking about today, the corpus callosotomy is the only one that's irreversible. You can remove devices. Well, as Raj mentioned, you cannot remove the electrode from the vagal nerve easily, but you can remove the vast majority of the devices. And of course, it is an actual brain surgery. Whether you do it with laser or open, an incision is still being made near the center of the brain. Experience is key in this procedure, having a surgeon who has done this before. So what is it? The corpus callosum, it's a major structure that basically allows the communication between the two hemispheres, which is both good and bad. It's good when you want the two sides of your brain to be helping your body coordinate movements, but it's bad when seizures are, when seizures are propagating. When the surgeon does this open, there are, unlike when you do sort of what we tend to think of as like tumor surgeries or your real traditional brain surgeries, they're not actually cutting into the cortex, the big curly parts of the brain, but they do have to approach that between the hemispheres, and there are some major blood vessels that go there. Now that we have laser ablation, I'll talk a little bit about the practicalities of that, but it is an alternative. So, really looking at the practicalities, obviously it takes place under general anesthesia, and it's a longer surgery than a vagal nerve stimulator. You're talking about 4 hours of actual surgery. And the craniotomy incision usually is right here, sort of the front top of the head, and a small window of bone is temporarily removed. Then the surgeon does what he needs to with separating the two sides and making that incision, and then replacing that bone and closing up the covering of the brain. Because it is an actual open surgery, obviously you're in the hospital for much longer, though I have seen individuals make it home within 3 to 4 days. Whenever somebody has a surgery that involves opening the skull, you're going to see a lot of facial swelling those first few days. It looks like you've been through a boxing round, 2 black eyes. But that gets better after the first 3 days. It has to do with the swelling that's basically gravity is taking effect. At our institution, I think it's pretty standard, the first night is spent in the ICU, so we can do very frequent neurologic checks. And then usually you go up to we have a neurology floor with careful monitoring, therapy involved as needed, and we're looking for all of those things you look for after a surgery: tolerating nutrition, pain control, bowel movements, healthy, not having fevers, getting back to themselves. With laser, the recovery is better. The operation still needs to take place under general anesthesia and still takes just as long. But what's interesting is about half of the time is getting the person positioned very precisely, and they use MRI guidance for that laser. And so the child or adult is placed into a frame. It's very important that the head not move, because the laser part doesn't actually take that long, but there's a lot of time of verifying placement of things. And then the corpus callosum is divided using the laser. We still have our patients stay in the ICU overnight, but recovery can be much faster because you just don't feel as bad when you have not had a craniotomy. You know, it's as far as an incision, it feels much less painful. Okay, so yeah, I wanted to make sure I had remembered to include a couple specific points. So when you think about open versus laser, one of the questions you might ask is, do they work just as well? And this is broad pediatric epilepsy data, but there have been numerous studies that do show similar efficacy. So as far as how well the technique works and what it does for seizure control, it does seem to be similar. There is no specific CDD data for laser. There is less blood loss and shorter hospitalization with laser, but it may not be anatomically possible to have laser for every person. So the corpus callosum is usually generally shaped like a somewhat flattened C, but for some people it's flatter than others, and because the laser is a straight, and I'm not the surgeon, but the surgeons have explained this to me multiple times, you can only place so many probes, and so the number of probes and the angle at which you're placing them can affect whether you're a candidate for laser. Also, the thickness or thinness may affect, if it's too thin, you're not a candidate for a laser callosotomy. Finally, a laser technique may not allow for a complete corpus callosotomy. You may only be able to do closer to a 2/3 or 4/5, if you will, depending on the exact shape. In some cases, I have had patients where we went back and did a posterior completion later. But so, just so you know, there's some details to this always, right? There's always more. So why am I talking so much about this? Well, I trained at WashU, and we actually have a very long corpus callosotomy tradition. And I take care of a lot of patients with epileptic encephalopathies from a variety of causes. And so I probably have 2 to 3 patients a year who do get a corpus callosotomy. And for some of them, it has really been life-changing. Not all of them, but for some of them. Periods of seizure freedom, marked improvement in what we call encephalopathy, that brain fog or that developmental change that comes with spending so much time with your brain in a seizure state. And even when it doesn't result in seizure freedom, I have seen many situations where we can decrease the total number of medications. I kind of included a couple of our retrospective series of corpus callosotomy as a whole up here, in case you're wondering what these articles are that I have up here. And we have evidence that encephalopathy can be improved with corpus callosotomy, including some fMRI studies. Unfortunately, I would love to have this for CDD, but it hasn't been done yet. I wish that I had known about this one patient that we did, who was actually, this is one of my patients in this paper, but he does not. Actually, he remains undiagnosed 15 years later. Because it would be very interesting to see if the improvement that we've seen in some individuals in what we call connectivity can be demonstrated in CDD. But unfortunately, we don't have that data, and it's very complicated to organize these studies when you're weighing all the risks of the surgery itself. I have 2 patients who have personally had corpus callosotomy, and one is now 21 years old. She had it 11 years ago, and the other is 13, and she had it about 10 years ago. She also has a VNS. Just so you can see the range of outcome, the 21-year-old is walking on her own and continues to have improved seizure control. She had improvement in her seizure control immediately post-surgery. So she went from multiple daily tonic seizures to now weeks to months where she does not have clear seizures or they're subtler. And then unfortunately my other patient has not done as well. She continues to have daily tonic seizures, though she did have a seizure holiday after her corpus callosotomy. She also overall struggles a bit more developmentally, so she's unable to sit independently. So one patient, I would say, was a really big success, but the other one, not so much. And if we could predict who that would be ahead of time, it sure would be helpful. What about bigger data sets? Well, that paper I referenced earlier that Heather headed up that I was on as well, we had 5 individuals in that series, of which 3 reported a response. And of course, we have variation in follow-up time, but one had significant reduction, but eventually had recurrent seizures. One had reduction in how long the seizures lasted, and one had resolution of what are more like loss of tone seizures, atonic seizures, but had recurrence after a year, but at lower frequency. And there is also one published study out of Japan that had 3 patients with a complete corpus callosotomy out of a series of 29, and 2 of them reported that greater than 25% reduction in seizure frequency. I'm very aware of how limited this data is, but this is what we've got, so that's what I'm sharing. So Pros, it's minimally invasive if you can have it with laser. It may improve the encephalopathy and decrease the severity of the seizures. And it doesn't require a lot of long-term follow-up once you've had it done, as opposed to these devices I'll be talking about and the VNS, as I already discussed. I strongly consider it most if your child is falling with their seizures and having head injuries. And my gut tells me that we're probably underutilizing it, but I really get the dilemma when we're hoping for a true to-the-source treatment, because these treatments are not to the source. Ultimately, it is a true brain surgery, and you cannot undo it once it's done, and it does not result in seizure freedom. So those are obviously the big cons. My final big topic is deep brain stimulation, and I'll be talking about RNS a little bit as well. So I have two images up here. The top is sort of trying to show you what deep brain stimulation looks like in its traditional sense. And RNS, as you can see, was actually created for focal epilepsies, where we have a target or 1 to 2 targeted spots in the surface of the brain that for whatever reason a surgery where you remove that tissue can't be safely done. But what is now being explored is whether you can use the technology of RNS, so the device itself sits within the skull, but your targets are the same as DBS. And that's what Dr. Raj was alluding to with the paper he was involved in, where you're using responsive stimulation to the thalamus. So deep brain stimulation. It was actually developed for Parkinson's disease and has been FDA approved since the 1980s. For any of you who are Back to the Future fans, Michael J. Fox got one for his Parkinson's treatment. So the technology of deep brain stimulation is not new. What has been new is the development of DBS for epilepsy. And it has been approved since 2017 for drug-resistant focal epilepsy in adults, and with everything that gets approved or is being looked at, we've been using it off-label from the beginning. That means generalized epilepsy, that means adults and children. But I should mention that whenever, I'm sure you all know, whenever you're trying to use off-label, particularly for something like DBS, the insurance is going to ask a few more questions. There are now multiple studies looking at DBS for Lennox-Gastaut syndrome. And as I mentioned, the off-label combination with RNS technology, which brings two benefits. One is that you don't have to deal with a two-part surgery that a traditional DBS involves, and the responsive component that traditional DBS does not have. So traditional DBS, you have a device usually placed in a similar location to where the VNS device is placed, and then you're sending wires to the thalamus. The thalamus is kind of like an egg-shaped area of the brain that is very rich in nerve cells and is a relay center to the brain. And it actually has, how many different nuclei did we have to memorize for our neurology boards? A really lot of sub-areas. Two main ones have been targeted in the epilepsy studies, the anterior nucleus and the central median nucleus. And the vast majority of studies for Lennox-Gastaut syndrome have looked at the central median nucleus. I mention this in part because Dr. Benke this morning talked about a study in mice where they used deep brain stimulation, but the target in those mice wasn't even the same as the target that we use in traditional human surgery. So a lot of questions as to whether DBS could be more effective. Similar to VNS, the device is here and then the wires, but this time the wires are going into the brain. So, and I'm realizing I'm maybe a little behind time, so I'm going to start talking faster. Sort of the same concept as VNS, and it is battery operated, and it does require programming and clinic visits. And I think this is actually really important. When we started using DBS for epilepsy surgery, one of the things that our nurse coordinators and I started noticing is we weren't prepping families for just how much you're committing to up front. It gets better once you get further out from the surgery, but at the beginning, there is a lot. First of all, very special MRI sequences have to be done, and obviously under sedation, because the neurosurgeon needs really good visualization of the targets they're going for in the thalamus. It's a two-part surgery. When the leads are actually at our center placed first, and that's when you are putting something into the brain. It's very small wire, but There are also very important small areas, and so making sure there's no concerns for bleeding or infection or any problem with something getting hit that wasn't supposed to in the surgery. Very rare, but obviously this is a brain surgery. So they recover in the ICU. The stage 2 surgery at our center, and I think this is pretty standard, is done approximately 1 to 3 weeks later. This is out of concern for infection because if you're operating on skin and brain at the same time, at risk of infection. And that is the stimulator placement where the leads then get attached. That can be done as an outpatient surgery just like VNS. Then you have to start coming to clinic and getting the device programmed. Over time, those visits space out. Some of it can be, those check-ins can be done via telehealth, but you're looking at about every 3 to 6 months for clinic visits over time, just for monitoring of the device. Overall, side effects have, step away from my, side effects have not been a significantly reported issue. There's sort of a lot of these reports of symptoms that, you know, you just had big surgery. It's hard to say. But we will tinker with settings over time to take a look. And I'm very aware that for individuals who struggle with communication, we might not know about all of these symptoms. So some take-home points for DBS. It's a 2-part surgery. It does require in-person visits. If you're looking at any literature, you do want to look at the literature specifically for centromedian nucleus and Lennox-Gastaut syndrome at the moment. One other thing I do think is important to know is that it is possible to have a VNS and a DBS at the same time. When that happens, the stimulators gets placed on the opposite side. Overall, the side effects have not been a big issue. What do we know about it in CDD specifically? Nothing officially. I've talked to a couple of my colleagues, and I know that at least one, and actually, have you done it for CDD? No. So at least one center has placed it for at least one patient, is what I can say, out of respect for HIPAA. It wasn't at WashU, that's all I'll say. It wasn't WashU or UCLA. But there's no published data. So I listed off a bunch of studies here that are pediatric specific and Lennox-Gastaut specific. And depending on the study, they looked at response, and they're looking for a decrease in number of seizures. And all of the studies have shown over 50% response rate, which is good. But what does response really mean? You know, is it I was having 8 seizures and now I'm having 6 seizures a day? But there, you know, I kind of listed the statistics here. So, kind of looking at pros and cons, it may be safer. I mistyped there. It may be more effective, is what I mentioned right there, sorry, than VNS or corpus callosotomy. It can be removed easily, and it can be removed completely. Now that is a pretty big deal, but in talking with my colleague who does the most work on neurostimulation at WashU, he really thinks in many ways it's less of a commitment, as crazy as it sounds, because we place those electrodes into the brain. It is intriguing, this idea of using the RNS technology where we'd be able to do responsive stimulation and do it as a 1-part surgery. But the cons are, again, 2-part surgery, no good data for CDD yet. The other practical thing is you cannot get MRIs of the neck or chest, and MRI of the brain requires caution and a lot of discussion with the radiology suite. So it does add a hurdle if you need to get imaging in the future. So, great, I just gave you a bunch more options with limited data. How do you make a treatment decision? It ultimately comes back to what's right for your family and your child. What are your primary goals? What are you dealing with right now? And I would mention, it's okay to get multiple opinions. I can be a very opinionated person, but I also will say that, you know, I'll jokingly say my way is the right way, but I don't really think that, you know, because there's more than one way to get improvement. I would mention, though, if you are seriously considering a surgery, particularly callosotomy or DBS, those are not done at every neurology or epilepsy center, and it is important to ask the surgeon, how many of these have you done? Because there are some very technical and risky components to the callosotomy and DBS. Think about what things worry you the most. The anesthesia, the fact that it's irreversible, and so on. There is no data that says this treatment is better than that treatment. I'd like to have that data for you, and I'm going to do a quick personal plug there. As part of the ICCRN U01 study, we are trying to gather data on epilepsy surgeries. So if you have had an epilepsy surgery and are part of that study, there is another survey that we're hoping to have your provider at that center fill out. Unfortunately, none of these are cures or disease-modifying treatments. So that is for all the more reason why there isn't one right answer. But ultimately, the key thing is to be aware of the potential benefits and risks and determine what is the best fit. These are just additional tools in your toolbox. They can be used in any combination, and work with your primary neurologist.